So let's start with a simple case. It's a 57-year-old male diabetic with no family history of glaucoma, already using anti-glaucoma medication with 6/6 vision and 16 and 15 pressures on beta blockers and prostaglandins. Open angles, both eyes. This is how the optic nerve looks like. So you can make out that NFL defect in the right eye. Very good. And in the left eye also inferior NFL is darker. Maybe the picture is not very clear to appreciate that. These are the places where the darker NFL is starting, the arrows that you can see. Okay. Closer look at the nerves. Look at the defects. Now, the defects are not telling us anything about the nerve fiber layer defects that we are seeing. Okay, so let's go further. We did a imaging for this patient. This is OCT. So I'm just giving you one image of the OCT. So you can make out the clinical, your clinical judgment correlates much more with the scan here than the visual fields. So what do we do here? This is a classical preperimetric glaucoma. Okay, very simple as that. Now, usually if we talk about treating a patient of glaucoma, we talk about changes in the visual field unless we see the functional change. But if you have a very classical clinical picture which is matching with your scanning, you can go ahead and treat. And that's how this patient was on treatment already, considering preperimetric glaucoma. Right. The next case, a 65-year-old male with good vision, 6/6 parts, 6/9 parts, pressures being normal. The nerves look like that. The inferior and temporal rim look sloping. There is a peripapillary crescent. Look at the fields. If you go back to the disc, you can see inferior and temporal rim looks little suspicious there with a peripapillary crescent here and a superior arcuate in the right eye. But we need to look even closer. That means not only at the optic nerve, the whole fundus. So, what do you see? In the right eye, inferior, near inferior vessel, those are the pigmentary changes. That is again sectoral retinitis pigmentosa giving rise to these defects. So, we can have coexisting conditions like that where you have a disc suspect along with some retina problem or a neuro problem. So we have to look at a overall picture. Even if your disc was correlating here with the visual fields, we don't stop there. We have to rule out other things before we label the patient as glaucoma and start treating. Okay, another field here. Let's look at the fields first here. The right eye more or less looks okay. Peripheral defects. Left eye, concentric field. Moderately advanced glaucoma if you consider this as glaucoma, but a significant amount of, again, it's a vein occlusion which is giving rise to this kind of a picture. So if a patient comes to you with a field and a treatment, doesn't mean our checkup ends there. We have to look at the other things. So it's a branch retinal vein occlusion giving rise to defects like that. Another patient, 52-year-old male with the history of road traffic accident, having angle recession, pressures being 18 and 20, being borderline in the left eye, vision little less in the left eye, recent trauma. Look at the discs. Look more or less okay, isn't it? So, look at the fields. What say? Sectoral defects, more central rather inferior defects. Now if you look back at the nerve, doesn't look like superior nerve rim thinning or anything. So again, take a closer look. What is that? Choroidal rupture and edema. Okay, so that is blunt trauma. So a lot of things that we have to look at, not only at the fields, we have nerve and the retina, other things going on along with this. I'll hand over now to Jyoti to give us some more interesting cases and then I'll come back to you. Yeah.
Okay, so these 6 questions we need to ask every time we look at fields. I'll just go through it, that the field is unilateral or bilateral. Does it respect the vertical meridian? Is there a pattern? If bilateral, it's the defect homonymous. If homonymous, which side is the defect? And is the defect congruous? So let's look at this. So we know it's bilateral, so the lesion is definitely behind the chiasma, agreed, right? So then we go to the next question. Is it following the vertical and the horizontal meridian in this case also, right? Yes, right. So then we go to the third question. What is the pattern? It's within the vertical and the horizontal, so can we call it as a quadrant anopia? Right, so it's a quadrant anopia, and where is it most? So which side it is? So the left side, it's homonymous because it's on one side. So it's a left homonymous quadrant anopia, right? So what is it? Pie in the floor. So when you have a pie in the floor, where is the lesion that you're suspecting? Yes, so it's a right. Because it's a left field effect, the disease will be in the right side, so it's a right parietal lesion, right? So when you get a field like this, you have to look and see the same thing. Usually in neurological cases, if they are young patients, you really don't get that much of a generalized depression, so you can in fact look at the gray scale, and if there is a lot of confusion, then you need to go to the pattern deviation. So let's look at this another patient, 46-year-old female, known case of diabetes with poor control. Right eye vision was okay, 6/9, had a cataract, but left eye 6/24, had left RAPD. Here there's a left eye, right eye. So what do you see in both the discs? Left eye you see a disc edema, right? Even right eye there is a hemorrhage which is seen superior to the disc, right? So let's look at the fields. This is what we get in the fields. So let's reapply them for each case. Left eye, you're getting a superior arcuate scotoma. Now you look carefully. What is there? This part is swollen, but this part is pale. So this is the problematic part of the eye, not this. So when we tend to look, we look at the swelling, which is here with this increased Kestenbaum's number of vessels, hemorrhages. But this is the sectoral pallor that has come into, and this patient has therefore a superior arcuate scotoma. So this patient has an anterior ischemic optic neuropathy. Again, as I said, the previous picture shows that it is a unilateral disc. Unilateral field loss, so we are looking at a lesion of the optic nerve anterior to the chiasma, right? So that we directly decide what it is, and then we have a disc edema which is matching this particular field defect, so it's an anterior ischemic optic neuropathy. Similar, the other eye actually, in view of the poor control, doesn't have a significant defect, but this is a diabetic papillitis. So let's again look at this. What side of thing? Again, bilateral, right? So it is a neurological field. Both are following vertical meridian, but is it homonymous or not? It is not. It is heteronymous. So when you're looking at heteronymous, what lesions are we looking at? Chiasmal. Only two. It's either pituitary or it is craniopharyngioma. So this is basically, and there is a temporal pallor set in already. So it's a pituitary adenoma. Now what is this case? We are looking at one field. Definitely this is following a vertical meridian. So we know that this is a neurological field. In this eye, if you look closely, this is also having more denser temporally. That means it's following the vertical meridian, but this has involved nasal. And I told you that there's an exception in cases of heteronymous cases where the entire nerve can also be involved. In which conditions? When there's a chiasmal lesion. So when the pituitary macroadenoma starts compressing anteriorly on the optic nerve, then it no longer follows the vertical meridian. So if you have something like this, as I said, all those junctional scotomas and all come into play when anything is of the chiasma. So initially, if you have something denser, which is seen here, denser temporally here, but now encroaching here, you can still think of pituitary macroadenoma. Then let's look at this. Now this is again simpler, bilateral, so neurological, does follow the vertical meridian, so, and it is basically following the horizontal as well. This is in the right upper, so it's a superior quadrant anopia, so we are dealing with a right superior quadrant anopia and a left temporal lobe lesion. This, when we did a scanning of the MRI, we saw these kind of spaces. These are small vacuolated appearance which were actually called as Virchow-Robin spaces. Okay. Then now let's look at this patient. Again, this is an octopus field, but since in view of the generalized depression, we are looking at this plot. So what you notice here, can you see both the temporal fields are affected, right? This is the temporal part of both the fields. So again, we know it's a heteronymous defect. But when it's heteronymous and it is seen denser inferiorly, what are we looking at? As I said, heteronymous defects can either be denser inferiorly or denser superiorly. The denser inferiorly, we are looking at craniopharyngiomas. If we are looking denser superiorly, we are looking at pituitary adenomas. But usually when they present to us, it's very late. But in this case, it's denser inferiorly, so we know it's a craniopharyngoma. This patient underwent surgery. 3 months post-op, you see the fields have totally become all right. Now he's gone into Humphreys, so we are fine. But he came 4 months later saying that there is some discomfort in the left eye. Is this tumor recurrence? We checked his vision, it was 6/6, it was perfectly fine, discs were normal, color vision, right eye was normal, left eye was abnormal. But notice here, now what has happened? If we are looking at a recurrence of craniopharyngioma, where should the defect be? Temporal field or nasal? It should be temporal, right? But what is happening now? This has come to the nasal field. How is it possible? So we kept on wondering. We talked to the neurosurgeon. They said, no, everything is fine. There is no recurrence. But within 3 weeks of this follow-up, notice what has happened. Now, this bitemporal hemianopia has become into a homonymous hemianopia of the right side, which means, look here, it's shifted altogether. There's a left optic tract. When you do a decompression of craniopharyngiomas, eventually they decompress, but when they regrow, they can grow into any way. So this has regrown and affected the right optic tract. So it's regrown and now affected the right optic tract. That's why the patient, so even if there's a case of craniopharyngioma, depending on how it's overgrown, it can affect other parts.